that I'll be focusing a little bit on in addition to discussing the guidelines. So these are my disclosure. Quentin shared the prospect of the important concept of decision making. Instead of us recommending the patient what treatment you think will be best for them, I think a lot of the AUA guidelines move towards this concept of shared decision making, where you actually sit down and talk to the patients about the different risks and benefits of a potential treatment, because there's really a lot of treatments available for the conditions, and none of them really wins out against the others. You really need to sit down with the patients and talk about it, and allows you to empower the patient to make the right decision. You want to solicit what is important in the treatment goals, what do they want to achieve in the treatment, and based on that, you help them to form a partnership in this journey to treat their chronic pelvic pain. Again, nothing really works perfect for this condition. It's a chronic condition, so it's important to build rapport and to go on this journey with the patients all together as a close partnership. I think this is key to treatment success. Now, obviously, you need to assess the efficacy of the different treatment. Ineffective one should be stopped after a reasonable amount of time. Different treatment have different timeline, and we can talk a little bit more about that. It's important to consider multimodal pain management and multidisciplinary approach, because it is a very complex chronic pain condition. There are multiple factors at play here. It is important to do that, because if you just focus on one or two specific treatment, you may have to get up to the dose that is too high to give the patient side effects. It may be easier or better to consider treating it in a multimodal manner. Now, if you treat the patients and you're not making much success, it's important at a certain point to reconsider your diagnosis. Are you really dealing with a patient with interstitial cystitis bladder pain syndrome? Are you having a misdiagnosis of the conditions? Are the other thing you miss in your evaluation, they can actually have something else, and that's the reason why they don't respond to your traditional treatment for ICBPS. So this is very important. After you recognize the symptoms consistent with ICBPS, you always have to make sure that you rule out confusable disease. And Quentin talked a little bit more about that. This is actually the most difficult part of the evaluation, because many of us are not trained in all these other disciplines to rule out confusable disease. But this is crucial, because many of these confusable disease will present with symptoms very similar to ICBPS, and many of you know ICBPS is a syndrome based on the clinical symptoms that patient tells you about. So if you don't rule out confusable disease, you could actually misdiagnose the patients. There's a long list of that. Some of those are obvious: the cancers, the urologic, gynecologic causes, GI causes, pelvic floor dysfunction, infection, radiation, etc. And that's a long list of tables that you could take a look at in the textbook and in the literature. One thing that we talked about earlier with the concept of shared decision making is that we no longer tells you to do things with first-line treatment, second-line treatment, third-line treatment. You don't necessarily have to walk down this pipeline to manage the patient that way. This gives you the opportunity to really talk about many treatment modalities that are available and work with the patient with shared decision-making to pick the right modality. Depending on the severity and the patient goals, you could actually skip some of these steps and move to certain modality. This also gives you the opportunity to do multimodal treatment. You could do oral medication along with intravascular therapy. You could start with some procedures if patients have more severe symptoms. But in general, I think you should always start with non-pharmacologic and behavioral therapy, and we'll talk a little bit more about that. And in general, major surgery should be really be the last resort treatment. You don't want to jump to major surgery to start with. So these are the same boxes that you've seen earlier. There are really many different options for the conditions at different modalities. How are you going to pick them? Because any of you who've seen IC patients feel like this is what's happening. You kind of, okay, we're going to throw a dart and see if this treatment sticks. If it doesn't, we're going to try this other treatment and see if that one sticks. It is difficult. So what can we do to target specific treatment to a specific subgroup of this population? You have to right off the bat recognize that because it's a syndrome, it's based on clinical symptoms, the population is heterogeneous. There are different subtypes of patients, they have different pathophysiology, and therefore, if you believe in this concept, there will be different treatment for specific subtype of patient, and that's what I want to talk about in this context today. So I will kind of go a little bit slower on this slide because I think this is a very, very important slide to target specific treatment based on the phenotype. So let's talk about phenotypes. In the middle, you have IC-BPS, but there are different phenotypes. They are patients with bladder-centric presentations. So those are ones where the pain generator is located in the bladder. Obviously, it's the Hunner's lesion people, and people who respond to a local anesthetic challenge, meaning that if you instill lidocaine, alkaline lidocaine, or lidocaine or marcaine inside the bladder, and they got remarkably better. That tells you that the pain generator arises predominantly from the bladder. Those are bladder-centric patients, and those could be targeted specifically with certain treatment. For example, if those with Hunner's lesion, you could do a fulguration and triamcinolone according to the guideline statement. And those who respond well with a local anesthetic challenge in the office with a trial or intravascular installation, you could offer them intravascular instillation therapy as a long-term treatment. Now, there are people that are not only bladder-centric, but they may have pelvic floor-centric. The pain arises from a tense pelvic floor, high-tone pelvic floor dysfunction, attended pelvic floor on physical examination, and we'll show you data that pelvic floor physical therapy or using treatment to address the pelvic floor dysfunction will benefit those people. And then we'll talk a little bit about centralized pain. There are people where the pain is not just localized to the bladder or the pelvic floor. They actually have a lot of other pain syndromes all throughout your body. I'm sure everybody has seen the patients who come in with fibromyalgia, irritable bowel syndrome, and other chronic pain conditions. They have some psychosocial issues, and we'll talk about how to address it. But recognizing that there are different phenotypes is the key to start to address and individualize your treatment to these patients. So we'll go back to this. Everybody, I think, should have behavioral treatment and strategies offered to them because they are low risk. It is also empower them to do something to control the symptoms. Education obviously is very, very important. There are many, many resources available at the AUA, Urology Care Foundation, IC Network, and the Social Cystitis Association. Patient can learn about the conditions and the symptoms and how people manage it, holistically on their own. Again, this is about education, empowerment, and taking control of the conditions because they need to know that they have some control over the conditions and the pain and the symptoms. Now, these are some of the things that people commonly utilize. You could increase the volume of the fluid or dilute the urine, make sure they're not too concentrated. We talk about the interstitial cystitis diet. The idea is not to eat nothing and to lose weight because the diet obviously is very extensive. The idea here is to do a good bladder diary. You eat certain things and then your pain gets worse, and then you identify them as potential triggers, and you might want to avoid certain items. If you go for this long list of so-called IC elimination diet, it has hundreds of items. Most people may not even identify any triggers of the flare among all the items. Some people will only identify a few. So the concept is a healthy diet. Do a bladder diary, try to identify the triggers and stay away from the triggers. But not all items on the elimination diet will be triggers. And if you stick to that diet, it will be a relatively unhealthy diet. They use different temperatures and local support groups, support from family members and friends to help them through the journey. Stress reduction is important. We know that stress exacerbated the symptoms. It's not uncommon if you see a patient coming in for flares and you really kind of talk to them about, hey, what happened recently? It's stressful events, social events, family events, certain deadlines, they don't sleep well. So strategies to address stress and reduce stress can be very, very helpful. So these are some of the things that patients can do. Now, this all brings to the concept that educating the patients about the different holistic treatment options and modifying the behavior actually has an impact on the clinical care and on the symptoms. In fact, one of the randomized controlled trials from the NIDDK randomized patients to get amitriptyline, which is a pharmacologic management, versus education and behavior modification. So the placebo arm is education and behavior modification. While that's a very, very effective placebo, in fact, it was so effective that 45% of the people in the placebo arm who did education behavior modification reported benefit. And in fact, the delta of adding amitriptyline is so small that the overall trial is negative. So this illustrates the importance and the effectiveness of education and behavior modification. I think every patient should have it, regardless of the phenotype that you're talking about. Again, it's low risk, it empowers a patient to do something about the syndrome. Now, we're going to talk a little bit about each of the phenotype in a little greater detail. We'll start with pelvic floor-centric patients. So those are patients with high-tone pelvic floor dysfunction, or if you do a pelvic examination in them, they will have tender pelvic floor when you palpate different areas of the pelvis. Now, in women, obviously, this is a vaginal examination, but in men, this will be a transrectal examination. Often, I think men don't have a good pelvic floor examination because neither the patients or the clinicians want to do a transrectal exam on the pelvic floor. So I think we miss out a lot of opportunity, particularly in men with chronic pelvic pain, not recognizing men can also have pelvic floor dysfunction and that they can also get better with the right treatment. Now, many of you knows about this randomized control trial. There were many randomized control trials that the NIDDK has supported, spent tens of millions of dollars randomizing patients with certain treatment against a placebo or comparison arm. Hundreds of patients involved in the trials. It takes more than a decade to do, but this is pretty much the only randomized control trial that actually show a positive results. So these are women with pelvic floor tenderness on examination where they randomized to get either a global kind of relaxing massage throughout your body versus myofascial physical therapy. Now, the ones that do myofascial physical therapy do a lot better. I think this screen went off. This is still okay. So 59% of the people responded well to pelvic floor physical therapy versus 26% with global massage. So this is a level 1 strong evidence of targeting specific treatment for patients with pelvic floor centric pain and pelvic floor disorder. And we think you should do this. Now, what makes it more difficult is doing a standardized pelvic examination. We illustrate this with a paper, and there are actually a couple of papers out there. This is what we did with the MAP study. It's a multi-site study. We teach our clinicians how to do a pelvic floor examination. So in this case, we illustrate with a woman. You're looking at the oval here in the middle as the vagina. You palpate 6 different locations for a vaginal examination. Left side, 3 points. Right side, 3 points. You palpate the anterior levator ani muscle, posterior levator ani muscle, and laterally on the levator, the obturator internus muscle. So it's like 2, 3, 5, 7, 9, 10. It's relatively easy to remember. Think of this as a clock. 6 different points on the clock and 6 different locations to palpate for pelvic floor tenderness. This is relatively easy to remember. It really doesn't take too much time to do a pelvic examination like this. Now, in the men, you will do this transrectally. Now, we'll move a little bit to oral medications. Again, pain management. Many of you is aware of the difficulty of prescribing patients with chronic pelvic pain medications. There are side effects. There are catches up with this, and you should look at the AUA white paper position on this and be familiar with the CDC guideline. But the bottom line is maybe you should stay away from prescribing chronic opioids to start with. Urinary analgesics, acetaminophen, NSAID, non-opioid option is something you want to consider doing first. You could do multimodal therapy with a combination of this and other treatment that we'll talk about in the other guideline statements. But if you feel compelled that this patient need to have chronic pain management with chronic opioids, I would suggest you refer to your chronic pain management specialist who can actually, look at compliance and counting the pills and making sure they sign the pain agreement and things along that line. This might be too much for a typical practicing urologist to manage. Now, these are some of the options for oral therapy. Amitriptyline, we have the antihistamine, and we'll talk about pentosan polysulfate, which is Emron, many of you are aware of and have used in the past. Amitriptyline is a systemic therapy to improve the symptoms of ICPPS. There was, in fact, trials comparing amitriptyline, as I mentioned earlier, compared to the placebo arm, which is behavioral therapy. There are added benefit of amitriptyline if you go up to a higher dose. In this case, in that trial, is 75 milligram at nighttime. Now, we always recommend people to start with amitriptyline at relatively low dose. You can start with 10 milligram and see how the patient tolerate, because side effects is not uncommon, and it can compromise the quality of life. You're trying to find a balance at the right optimum point where you help them to control the symptoms, but they ain't at the same time not worsening the quality of life too much with side effects. So the key and kind of the secret sauce of a lot of this is trying to find this right balance, and this will be different for individual patients. Now, these are some of the side effects potential with the use of amitriptyline. You could also do nortriptyline, which is usually a little bit better tolerated in patients, particularly in older patients. That's another option. There are antihistamine available. Cimetidine is an H2 antihistamine. Hydroxyzine, many of you is aware of, or Atarax is the other name of it, is an H1 antihistamine. I personally will give this to patients who have systemic allergies. So this is one of the questions I will ask our patients, because it seems like there's data support that people with allergies might respond better with this particular treatment. I think we need more studies on that. Again, you start with low dose at nighttime, 25 milligram, and then you could titrate it up depending on how they respond with symptom improvement versus quality of life and side effects. There are side effects of sedation, etc. That's why you use it at night. Pentosan polysulfate, many of you is aware of this. Emron is really only FDA-approved oral treatment for the conditions, but then it is actually controversial in two perspectives. Number one, some of the earlier randomized controlled trial that shows very positive results was not reproduced in some of the later clinical trial when the entry criteria to the trial is changed a little bit. And also, many of you is aware of potential visual issues with macular damage in these patients. There's a specific entity called retinal pigmentary maculopathy that can be associated with chronic use of Emron or pentosan polysulfate. Symptoms include difficulty reading, difficulty adjusting to change in the light environment or intensity, blur vision. There are case studies, there are series of reports of this, and the risk appears to be increased with cumulative use of Emron. No people really know how common this is or how rare this is. the really worrisome thing is that once it's become a problem for your patients, stopping the medication do not reverse the macular changes. So some of these visual changes, sometimes even including blindness, is not reversible if you discontinue the medication. So there are some new FDA guidelines on the use of pentosan polysulfate. You should have a history, see if the patient have any eye problems. For those with eye problem, maybe you should send them to the ophthalmologist to take a look at it before you start the medication. A retinal examination is suggested 6 months after initiating therapy. A lot of these therapy, it really takes 3 to 6 months for it to start working. So you should think along that line if that's what you choose to start the patient with. And you should check them, I think, regularly. If there's issues, obviously you send them to your ophthalmologist to try to address that. I personally haven't started any patients on Emron in the last few years, so there are many different modalities and options available. So this is one I would personally stay away from myself, and I could see what the other panelists will say later on. Intravesical instillation. Now, many of you do this in the office. There is no magic bullet. There's many, many different type of cocktails available. Not clear if one is better than the other. You could use lidocaine, alkalized lidocaine, lidocaine with marcaine, without heparin, without triamcinolone, which is Kenalog. Again, these are targeted for patients with bladder-centric type, meaning that the best patient that responds to this is just plain logic, is that if you have a patient who comes in, you do a test intravesical installation, okay, and they improve a lot, you could conclude that a lot of the pain generator is located inside the bladder urothelium. So those technically and logically will be the best patient for you to manage this. Now, usually, this is not going to be the only therapy you offer to the patients because, doing installation over and over again is time intensive and it's very intensive for the patients too. But this is obviously one of the modalities that you could offer to the patients. If the pain improves after a test intravesical anesthetic challenge. In my office, we typically would put in 15, 20 cc of lidocaine with marcaine and have the patient rate the pain or discomfort before and after the installation. We'll do a pelvic examination with the pelvic floor also. Now, if they responded well, obviously this could be a good targeted treatment for those patients. Now, if they don't respond to this, it doesn't mean they don't have interstitial cystitis. It just means that the bladder may not be the pain generated in this case, and you need to look and see, what is causing the pelvic pain. Okay, procedures. Many of you do this, cystoscopy. We talked about cystoscopy a little bit earlier. We'll talk a little bit more about this. It's two things about cystoscopy is for diagnosis and for treatment. Now, hydrodistension is done for some patients as a therapeutic treatment approach, but for diagnosis purpose, there's really two reasons to do cystoscopy. Number one, you want to rule out other things that may mimic. You really don't want to miss a tumor or something going on inside the bladder causing very similar symptoms. I would say that one of the most embarrassing I've ever done is I have a man who see me for what sounds like classic interstitial cystitis, for which I have never done a cystoscopy on the patients, and then find out 1 year later that the patient actually have a 2 centimeter bladder stones causing all the pain that he has, and after I have done a laser of the stone, the IC disappear. That's very embarrassing. So you need to look for some of these other things, that could be mimicking. And of course, if patient have hematuria, you go to the AUA guideline, risk stratify them, and I think cystoscopy is very, very reasonable for anybody with a history of smoking, family history of bladder cancer or hematuria, or you suspect, is it a stricture? Is it BPH? What is going on? Have a very low threshold to do a cystoscopy. That's to rule out other pathology. I cannot emphasize the importance of that. But as we mentioned earlier, we also want to identify Hunner's lesion. because those are the classic bladder-centric patients. The reason we say this because they got a lot better with bladder-centric treatment. These are some of the classic presentation at appearance on cystoscopy. In the middle, there's a little red spot and radiating like a little sun ray. You see this blood vessels coming out, so there's neovascularity, inflammatory changes in those lesions. You could see this on cystoscopy. In the office, you don't have to bring them to the operating room and give them general anesthesia, have an IV and make things very, very expensive. You could do this in the office with flexible cystoscopy. We have done hundreds of those in the office. Most of the patients tolerate really well. And once you go inside the bladder, the Hunner's lesion is either there or not there. You don't really need to distend the bladder to 1,000 cc to be able to see it. So this is important. Sometimes if you bring them to the operating room, you see little spots in the bladder. So on the left, if you see A, those are called granulations. Those are not pathognomonic for interstitial cystitis. Those are submucosal hemorrhage in response to bladder distension. Now, sometimes if you bring them to the operating room, you see a little red spots in the middle, and when you distend the bladder starts to crack, and you start to have what we call waterfall bleeding. The bladder is literally cracking open in front of your eyes when you distend the bladder a little bit. Those would be considered as interstitial cystitis with Hunner's lesion. Okay, so the strong recommendation, obviously, if you have Hunner's lesion inside the bladder, you should do fulguration and/or triamcinolone, which is Kenalog injections directly into those lesions. It is a very, very specific treatment targeted at the lesion. Again, if you don't do cystoscopy to try to identify Hunner's lesion, you would not know that they have Hunner's lesion, and you would not be able to individualize the treatment of these patients based on this specific phenotype. The data is pretty robust. How many people do triamcinolone injections or cautery for Hunner's lesion? Anybody want to raise a hand? Not enough people doing this. We need to really recognize what Hunner's lesion is like and use this more commonly, because if you have done this on your patients, they do remarkably well. We're talking about something that really changed their lives. They could report significant improvement of the pain, and that could last anywhere from 9 months, 12 months, 15 months. Eventually, these Hunner's lesions will come back, and they will need repeated treatment. But if one single treatment in the operating room that lasted, 15 minutes, can buy them 1 year of significantly improved quality of life, I think that's something you could make a major impact in the treatment of these patients. Okay, there are other procedures that you can do. How many people do Botox injection for IC? Oh, more than I thought. So good. I also do this. One thing you obviously have to worry about is whether or not you would put the patient in retention if you give them Botox, because that happens when you treat patients with overactive bladder. And that's probably the worst thing you could ever do to an IC patient, is to put them in retention, because he or she will have to catheterize for a couple of weeks, and it's going to be really, really painful. And because the bladder capacity is so small, they cannot even hold 400 cc. So we're not talking about cathing themselves 4 times a day. You could be cathing a lot, which makes it even worse because they have a lot of urethral pain and pelvic floor dysfunction, all that, and when you try to catheterize. But I think one way to stay away from the risk, I don't think you can completely eliminate the chance of retention. Of course, you have to counsel them about the possibility of retention and having to self-cath and really make an informed decision. But one way you could try to reduce the risk of urinary retention is to inject the Botox directly into the trigone area. This is where all the sensory nerves is coming in. You get the biggest bang of the buck trying to numb up the sensory nerve without distributing the Botox throughout the bladder, causing them to go into retention. And they are, in fact, good data from many different countries doing Botox injections into the bladder. Many of these studies will focus on trigonal injections. You still use 100 units, but what I typically will dilute it only in 1 to 2 cc of normal saline. That's a very small volume. And you would use a Williams needle to inject it directly inside the trigone. Usually I would do, 0.5 to 1 cc on the left side, away from the UO, obviously, and do a second injections on the right side, away from the UO, just targeting it directly at the trigon. I personally have not put any patients in retention. These patients tend to do well, but they may not last 6 months. That's my personal experience. Sometimes they will come back and ask for another injection. It's about 3 to 4 months interval. So you may have to do this a little bit more often than compared to the OAB patients. Obviously, it's not appropriate if the patients say, there's no way on hell that I'm going to cap myself. I mean, those will not be the proper patient. And of course, this is an off-label use for Botox. Sacral neuromodulation. Anybody does sacral neuromodulation for the conditions? Very few. Okay, I do too. It's not FDA indicated, obviously, for the label for International Society of Bladder Pain Syndrome. You could get insurance approval if you could argue that they have refractory unit frequency and urgency, because that's an important part of the symptomatology. Study shows that the frequency and urgency in urinary symptoms can improve significantly with a trial of sacral neuromodulation, and if they pass the trial, you can have a sustained response in this area, just like you would see with an overactive bladder patients or patient with frequency and urgency without incontinence, the so-called OAB dry patients. The pain can also improve. There's literature that shows that the pain can improve quite a bit, but not complete elimination of the pain. So this is something you can discuss with the patients. You know, you are waking up every hour to urinate at night. We try many different medications, including anticholinergics and beta agonists. It doesn't help you. You're not getting enough sleep. You're sleep deprived. Quality of life is miserable just from the urinary symptoms alone. Hey, this is some treatment that we could offer you, and we could do a trial. You could literally do a test drive, within those 2 weeks period. One good way I tell my patients is this is a test drive. You could actually see what it does. You might get improvement, you may not, but you're gonna experience what this therapy will do for you for the next week or two. Some patient will be open to the idea. You typically will get a good benefit from urinary symptoms, but some will get benefit with the pain also. So they could actually test drive and see what this therapy do to them and decide if they want to do a second stage procedure. Now, they do tend to have more commonly have complications. They're more likely to ask to have the explant removed. They're more likely to have symptoms recurrence or having pain at the generator site and things like that. So this is something you have to be aware. They are rechargeable ones that you could use for the generator. It reduces the footprint because some people might be very sensitive to having a bigger generator in the buttock area. So those are many different strategies that you could use in this population. We haven't found a good data on PTNS for this patient population when we look at the literature, but it will be nice, something to study in the future for ICBPS. I'm going to end this talk talking about major surgery. Anybody does major surgery with patient of IC with or without cystectomy, idiocondyle? Okay. So this is a new guideline statement that says major surgery may be undertaken in carefully selected patients with bladder-centric symptoms, or in the rare instances, you're not doing this just for pain, you're doing this because they have such an end-stage small bladder. Under general anesthesia, they have 200, 300 cc capacity. In real life, they may only have 2 or 3 ounces of functional capacity. The quality of life is miserable because of the small bladder capacity. You could also do this for this reason. But the key to this is, again, this is a treatment of last resort. You have to be extremely careful who you pick to offer this treatment. You really need to have a good discussions to the patients and what to expect from the treatment. The best predictors when we look at this in the literature, there's really not a lot of literature done in this country, but in other countries, there are series of patients who underwent different type of either diversion or cystectomy or substitution. The best predictors of success appears to the end-stage fibrotic bladder, very, very small bladder capacity, refractory unit frequency and urgency. The one with Hunter's lesion, where you try to treat them in many different ways that we talk about, triamcinolone, fulguration. We didn't talk about oral cyclosporin because that's also a very, very viable treatment for refractory Hunter's lesion. Went through all that. They have intractable Hunter's lesion inside the bladder. Those responded well to this type of treatment. Or very small bladder capacity. Now, these are the people who tend not to do well when you remove the bladder or give them a unidiversion. The recurrent theme here is that many of these patients probably have a phenotype that is not bladder-centric. The bladder capacity is great. They don't have Hunter's lesion. You instill local anesthetic, the pain doesn't change a bit. They have a lot of pelvic floor tenderness, refractory to treatment in that area. The pain they complain is mostly urethral pain, is a bladder pain, with, bladder filling or painful bladder urgency. Neuropathic pain, there may be some quality that makes you suggest that we're dealing with neuropathic pain conditions. Centralized pain, and we'll talk a little bit more about that. Many, many different complaints all over the body, we call it PSPS, polysymptomatic, polysyndromic presentations. Some somatic symptoms in multiple body organs. Non-compliant patients may not be good. Now, we'll give Quentin a chance to talk a little bit more about it, but this is a big elephant in the room. Patient with Hunter's lesion, I think, is relatively easy to manage. Patient with pain that improves with insulation is relatively easy. People with pelvic floor dysfunction, attendance is relatively easy to manage. This is a big elephant. There are people with what we call widespread pain, or they have centralized pain phenotype, or the other literature in the chronic pain literature is nociplastic etiology of the pain. It is a different phenomenon. It may be a top-down phenomenon. The etiology may not be at the end organ itself. The bladder is a bystander, is one of the organs that they have chronic pain. They tend to have fibromyalgia, irritable bowel syndrome, and other issues. And we'll talk about different treatment options for these people. When we did the MAP study, and Quentin will talk a little bit more about it, 2/3 of our patients actually reported pain outside of the pelvis. Those are men and women with interstitial cystitis and chronic prostatitis. Only about 1/3 of them have pain localized to the bladder. About 2/3 of them reported pain locations outside of the bladder. So there's clearly a widespread pain phenotype here. So the question, and Quentin will answer this with the data from the MAP study, is does the patient with widespread pain respond better to systemic therapy such as amitriptyline, neuropathic medications that work centrally? Or is there any evidence that patient with localized pelvic pain responds better to local therapy? Conceptually, this is very attractive. I will tell you the answer to both of those questions is yes, and Quentin will present a little bit more with the data later on from the MAP study. But I'm going to summarize this slide. You have seen this before. There are different phenotypes of interstitial cystitis patients, bladder-centric type, pelvic floor-centric type, centralized pain phenotype. Depending on the specific phenotype, you can actually target specific treatment for those patients. Fulguration, intravascular instillation, pelvic floor physical therapy, systemic treatment with systemic medication, multidisciplinary systemic treatment. But you can also do the phenotyping today. This is not, we move from research to something very, very practical that you can implement in the office today. You can do cystoscopy to identify Hunter's lesion today in your office. You could instill local anesthetics inside the bladder in the office and see if they improve to identify, to see if the pain is the bladder is the pain generator. You could do this today already. You could do a good pelvic floor examination on the patient to see if they have pelvic floor tenderness or high-tone pelvic floor dysfunction. You could do that already. I think it takes an extra 5 minutes to do it, but you could identify the phenotype and target the treatment because it's strong level one evidence these patients do well. You could even use a body map that we'll talk about later to identify patients with widespread pain. So all the tools is already available today in the clinic to identify the phenotypes and target and individualize the treatment of these patients to optimize the outcome based on the phenotype. Thank you very much for your time today.